Dr. Sambandh is presenting a case of arrhythmia. Right.
Good morning, sir. Today I am presenting a case of arrhythmia. My patient is a 58-year-old male named M. Lakshman Rao, who is working as a technician grade 1 in mechanical department in Kharagpur. Patient presented with complaints of sudden onset of palpitations and giddiness. Coming to the history of present illness, the patient had sudden onset of palpitations while riding a bicycle uphill, accompanied by giddiness and sweating. There was no shortness of breath or chest pain. There was no syncope or vomiting. Coming to past history of the patient, there was no history of ischemic heart disease in the past. The patient is not a known case of bronchial asthma, COPD or valvular heart disease. The patient is a known case of diabetes and hypertension since 2 years on regular treatment. The patient is not a known case of hypothyroidism. Coming to personal history of the patient is married, has one son, works as a technician, belongs to middle income group, no addictions, non-smoker, diet is mixed, there is no history of intravenous drug abuse or unprotected sexual exposure. Coming to family history, there is no history of diabetes, hypertension, ischemic heart disease or bronchial asthma in any family member. Coming to treatment history, for the past 2 years, good morning sir. For the past 2 years, the patient is on tablet amlodipine, 5 mg OD, tab metformin, 500 mg 3 times daily, and tab glipizide, 2.5 mg OD. At presentation, the general examination of the patient revealed, patient was well built and well nourished, no pallor, icterus, cyanosis, clubbing, lymphadenopathy or edema. JVP was raised at presentation, height was 160.4 centimeters, the weight was 56 kg. At presentation, the systemic examination revealed pulse was not palpable, BP was not recordable, and the JVP was raised. Coming to inspection, the precordium shape was normal, apical impulse was not visible, there were no engorged veins seen, no scarcer sinuses seen, no abnormal pulsations in other areas. Coming to palpation, the apex beat could not be localized. In the mitral area and pulmonary area, there were no palpable heart sounds, no thrills. In the aortic area, there were no abnormal pulsations, no palpable heart sounds, no thrills palpable. In the tricuspid area, no parasternal heave, no palpable heart sounds, no thrills palpable, no carotid thrill. Coming to auscultation, in the mitral area, first and second heart sounds were feeble, no murmurs were heard. In the pulmonary and aortic area, the first and second heart sounds were feebly heard, no murmurs were heard. Tricuspid area, first and second heart sounds were feeble, no murmurs or adventitious sounds were heard. There was no carotid buoy or venous hum on auscultation. Coming to the examination of the respiratory system, the upper respiratory tract was normal. Coming to the examination of the chest, inspection shape was normal. There were equal respiratory movements on both sides. Apical impulse was not visible. Respiratory rate was 22 per minute, regular, abdominal, thoracic. Skin over the chest was normal. The accessory muscles of respiration were not prominent. Over the chest wall, there were no venous prominences seen. Examination of the back was normal. On palpation, the inspectory findings were confirmed. There was no rise of surface temperature, no tenderness. Trachea was centrally in position. Apex beat could not be localized on palpation. Movement of the chest was equal on both sides. Vocal fremptus was normal. On progression, there was normal resonant tone on both sides of the chest. Upper level of the liver dullness was at the level of 5th rib in the mid-clavicular line. Good morning, sir. Coming to auscultation, vesicular breath sounds were heard equally over both lung fields and no adventitious sounds were heard. The examination of the nervous system was normal. The patient was conscious and oriented. Examination of the abdomen was normal. Coming to the summary of my case, a 58-year-old male, known diabetic and hypertensive since 2 years, presented with complaints of sudden onset palpitations on exertion associated with profuse sweating and giddiness without chest pain and syncope. On physical examination, a state of pulselessness was noted and BP was not recordable. The first and second heart sounds were feeble. Coming to the clinical possibilities, it could have been acute myocardial infarction with ventricular fibrillation, acute myocardial infarction with ventricular tachycardia, or it could be simple hypoglycemia or atrial fibrillation. Coming to investigations,
Someone, in spite of rushing so fast, you could have stopped there and asked your juniors what could be the diagnosis. That would have been much more interesting actually.
Coming to investigations, the random blood sugar was 453 milligrams per deciliter. The CKMB was raised 117 international units per liter, LDH was 591 international units per liter, and SGOT was 147 international units per liter. So the CKMB, LDH and SGOT, all the cardiac enzymes were raised, and the random blood sugar was also high, 443 milligrams per deciliter, and troponin T qualitative test was found to be positive. Other investigations, hemoglobin, total count and platelet count were found to be within normal limits. Blood urea and serum creatinine were normal. The electrolytes were found to be normal. Serum sodium potassium, serum sodium was 135 milliequivalent per liter. Serum potassium 4.2 milliequivalents per liter. Later, when fasting was done, fasting and postprandial blood sugar were done, it revealed 160 milligrams per deciliter and 176 milligrams per deciliter. The total bilirubin was 1 milligrams per deciliter. The SGOT was raised 147, SGPT was 50 international units per liter, and ALP was 133 international units per liter. Lipid profile, triglycerides 75, total cholesterol was 135, HDLC was 40, LDL was 80, and VLDL 15 milligrams per deciliter. This is the picture of the chest X-ray. This is found to be normal, and ECG revealed monomorphic ventricular tachycardia. This is the picture of the ECG at presentation. You can see monomorphic ventricular tachycardia at a high ventricular rate here. In V1 lead, it shows monomorphic ventricular tachycardia. Coming to treatment, in the emergency, a cardioversion was given with 200 joules of DC shock. After cardioversion was given, normal sinus rhythm was restored, and injection human activated insulin, infusion at 0.1 units per kg per hour was started. After cardioversion, the ECG revealed sinus rhythm. There was ST depression in lead 2, V3 to V6, T inversion in lead 2, V3 to V6, PR interval was 0.16 seconds. This is a picture of the ECG after cardioversion. And then echocardiography was done. It revealed left ventricle was dilated, left atrial size was normal, LV-IDD was 5.59 centimeters. There was good left ventricular function, mild mitral regurgitation and aortic regurgitation, no regional wall motion abnormality, other walls were found to be normal. Left ventricular ejection fraction was found to be 65%, no LA or LV clot, pericardium was normal. The consultant cardiologist was consulted, and he advised a coronary angiogram to rule out any ischemic cause of VT. And treatment, telmisartan 80 mg OD, amiodarone, cordarone 200 mg BD was started since the patient had ventricular tachycardia. Tab metoprolol 50 mg OD, tab prazosin 5 mg ODHS, ecosprin 150 mg ODPC, clopidogrel 75 mg, metformin 500 milligrams 3 times daily, and glimepiride 3 mg OD before breakfast was started along with statin. A coronary angiogram was done. It revealed 70 to 80% stenosis in the mid segment after the origin of large first diagonal artery in the LAD, and diagnosed there was 70% osteostenosis in the first diagonal artery, and in the intermediate there was 90% stenosis in the ramus intermedius. So the conclusion was there was a double vessel coronary artery disease which was the cause of the ventricular tachycardia. This is the picture of the coronary angiogram. You can see that in the intermediate branch and in the left anterior descending artery there was stenosis. An intervention, a PTCA with stenting to LAD and ramus intermedius was done on 18th March 2013. The patient improved and was discharged with the following medication: He was put on dual antiplatelet medication, ecosprin and clopidogrel, atorvastatin and metoprolol 50 mg OD. For hypertension, he was put on telmisartan, and amiodarone 200 mg OD was given, glimepiride 3 mg OD and pantoprazole. In the follow-up, the patient was asymptomatic after 1 month and 3 months. 3 months later, now the patient has joined duty at Kharagpur. And this is another interesting case of arrhythmia just 3 days back in the casualty. A 70-year-old woman named Deepthi Bishwas presented with a complaint of palpitations. On presentation, this was the ECG of the patient. There was a high ventricular rate of around